Thank you, Mr. Chairman. I want to emphasize what Senator Sheehy just said. As I looked over my notes and my questions, it all comes back to decent electronic medical records. You talked about coordination with community care. Good electronic medical records. Coordination with veterans coming out of the Defense Department. Decent electronic medical records. And it just, everything comes back to that. I mean, the over-prescribing or prescribing polypharmacy where there's conflicts and danger, that's where you get, that won't happen if you have decent medical records. So every practitioner that sees a veteran sees the same information about what they're taking, what they've been prescribed, what their history is, all that necessary background. So the development of electronic medical records for the Department of Defense and the VA has been an absolute debacle. And we're spending billions of dollars. It's still not working. It's been tested. People don't like it. I've never understood, frankly, why we didn't use the same system that's already on the shelf for thousands of hospitals across the country. Why are we inventing a whole new system for these patients? But sorry about the speech, but Senator Sheehy provoked it because he's absolutely right. A personal story. Just recently, I talked to an elderly friend, and in our conversation, I realized that she was much sharper and more engaged and with it than had been the case just a month or two before. And I didn't really think too much about it until I later talked to her husband, who said she had a fall, she had a broken knee, she went into the hospital, her physicians looked at her prescription record and changed the prescriptions, and she's a different person. Nothing else happened other than taking her off certain drugs, putting her on others, and adjusting the volume, if you will. And so this was totally obvious, and all it was somebody seeing cohesively what the prescription record was, and I'm sure that's happening with thousands of veterans. One question I have is, this seems to me a prime area where AI could help. AI could tell you whether there are contradictions and problems. I mean, I think that's one area. Everybody's talking about AI and all the problems, but this is something where AI could quickly and instantly analyze. It would have every drug in the world, and you put in what would happen if this person is taking these 3 drugs and I prescribe this. It would give you an instant answer. Isn't that true? You're nodding. Nodding doesn't show up in the record. You have to say, yes, Senator, that was a brilliant comment.
Yes, Senator. That is not a topic we've looked at in depth, but I do think you're absolutely right. And in terms of just even some of the record sharing, we do understand from VA in terms of them stating their intent to implement our recommendations that they do anticipate using medical technologies like AI. So I think just to loop back to the need for oversight and the need for more people, I do think there is promise that AI could alleviate some of that. We're very, very early, and that's not something that GAO has looked at specifically, but so I need to stop there, but I think it has a lot of promise.
One of my questions is there any part of the VA routine that involves an annual checkup of your medications? Is that something the VA does routinely? It seems to me that would be a useful tool.
I can take that question. So within an EHR, including the old CPRS that VA uses and the new Cerner record, when you prescribe a new medication, the software itself is taking that one medication against the list of medications a patient is already prescribed or against a known list of allergies the patient has reported. So what you're saying is happening in even the most basic EHR function. The issue is an alert can pop up that describes the risk level of that interaction. So the provider in that moment has to make a determination like, yes, I know this risk exists, but I'm taking the risk because it's worth whatever outcome or treatment plan I've established. So what you're saying is happening. It doesn't require new technology.
There are regular reviews of medication?
Every time you see a patient, this medication reconciliation process should be happening between provider and patient. But the software that they're using, when you enter a new medication, will run it against the inventory of what's already being prescribed to make sure those interactions aren't happening that you're worried about.
And one of the things you mentioned was a possible lack of communication and coordination with community care. Is
Yes.
That's correct? So that's a gap we should be paying attention to.
It's a massive gap that we've reported on frequently. There is a technological solution one day when all EHRs communicate with each other. That's the ultimate solution. We are nowhere near that.
And there's no excuse for being nowhere near that in this day and age. But I deeply appreciate your testimony, and I hope you'll follow up as a result of our questions and what the committee is after. Let us know what we can do to help. That's our job here, and you can be our eyes and ears in the field and say, here's a gap, here's a problem, here's where either oversight by this committee or legislation by this committee could help to fill those kinds of gaps. Thank you very much for your testimony. Thank you, Mr. Chairman.